This section is going to discuss Chapter 33 from your Med-Surg book regarding care of patients with infectious respiratory problems. Talking about the upper respiratory area first, and if you think about it, the upper respiratory disorders is going to affect your nose, your sinuses, your tonsils, your adenoids, the larynx, and the pharynx, including the nasopharynx or the oropharynx. So these are all body parts that are associated with your upper respiratory system. And a patent upper airway is necessary for effective breathing. So nursing care of these disorders focuses on maintaining the airway, managing pain and symptoms, promoting effective communication, and providing support for the patient and the family. Rhinitis is inflammation of the nasal cavities. It is the most common upper respiratory disorder. I'm sure all of you have had some rhinitis at one time or another. Typically it can be due to an acute viral or essentially the common cold. Or sometimes a chronic rhinitis is related to allergies. This is commonly known as allergic rhinitis or hay fever. Rhinitis is when there is inflammation of the nasal cavities that causes discomfort, headache, sneezing. Rhinitis is the most common problem of the nose. It often involves the sinuses. A couple causes: viral, or it can be related to allergies, and that is allergic rhinitis, also known as hay fever. An acute viral rhinitis is also known as the common cold, and there's tons of viruses that can cause this, and as you know, it can spread from person to person very easily, just from sneezing or coughing, direct contact. Typically, the common cold is not a problem for the patient unless they are somebody who is already immunosuppressed, and then it could lead to more severe complications because they don't have the defense mechanisms to fight off the viral infection. Hay fever or allergies is oftentimes seasonal because it's typically the body's hypersensitivity to things that are in the air, such as pollens or mold. I'm sure most of you are familiar with this. Some of you may be suffering from this at times. We're going into a change in the season, so a lot of times people, when there's a change in the seasons, they will go through, having some allergic rhinitis, which essentially leads to some nasal congestion, sinus discomfort. Management of rhinitis, whether it be viral or allergic, the focus of it is on relief of the symptoms and patient education. We need to teach them how to properly take their medication, and if they have allergies, they need to be educated about the allergies that they have. Okay, so like I said, the goal of treatment for rhinitis is to minimize or prevent signs and symptoms with minimal adverse effects and help them to just have a normal lifestyle. So just to maintain their symptoms in order and help them to be comfortable. That can be successfully done by the use of antihistamines and also education regarding, like I said, avoiding the allergens if possible. If it's dust and things like that, they can try to make sure that their environment is more free of dust, or if it's a certain animal or a certain type of plant, they can try to avoid that, of course, first. But antihistamines is another way that they can help treat their symptoms. And these are typically oral medications, and they can typically be gotten without a prescription. The first one, of course, we've talked about in the past is Benadryl. Benadryl does have some sedating effects, so that the patient would have to be educated regarding the sedating effects of Benadryl if they were choosing to take that. There's lots and lots of antihistamines out there that are non-drowsy causing, so they could be taken very safely, and that's like Claritin, your Allegra, Zyrtec, pretty safe medications that will decrease the antihistamine and hopefully decrease the swelling in the mucous membranes and make the patient a lot more comfortable.
Decongestants can be effective in decreasing the swelling in the nasal mucosa. They are often used along with the antihistamines. Neosynephrine, Afrin, those things are decongestants. Afrin and Dristan are topical decongestants that can be, they're like drops that you put in your nose, and they are just absorbed more topically as opposed to systemically. Anticholinergics are also medications such as Atrovent, and we'll talk about Atrovent more when we talk about like more pulmonary issues, but it's an anticholinergic that dries the secretions, so it will decrease the nasal secretions and thus helping someone with some rhinorrhea, which would be the drainage related to a rhinitis. Antibiotics, again, if somebody does have more of an infection, maybe they end up with more of an infection related to a rhinitis, treatment would be appropriate. Sinusitis is just the inflammation of the sinus mucous membranes that can kind of be a result of rhinitis if not treated properly. Can cause a lot of discomfort, headache, sinus drainage, sinus pressure. And these are the different types of bacteria that could potentially cause a sinusitis: the strep, Haemophilus, influenza, Diplococcus, bacteroides. It's just a picture of like the inflamed sinus here on a CT scan. So it just kind of gives you an idea of what that looks like.
Signs and symptoms that you'll see in a patient with sinusitis is increased nasal swelling, congestion, headache, facial pressure. A lot of us have had this sinusitis. You know how miserable it can be. They have tender sinus tissue if you kind of press on their area. They could have a low-grade fever with a cough and a purulent or bloody nasal drainage. All the treatments are listed here. They need some broad-spectrum antibiotics to make sure they cover the correct germ in order to treat it properly so that the patient gets better. A lot of times they need to increase their fluid intake unless they have a contraindication to increase fluids. Sometimes if the antibiotic treatment is not successful, if they take it properly, then they might have to do a CT scan to make sure that there isn't something else going on with their sinuses. And remember, all of your patient education regarding antibiotics, they need to take them all, even though they start feeling better. They need to take them as ordered. There are side effects of antibiotics, so they need to know which ones to monitor for. So we need to educate about all of that. So moving on down the respiratory system, pharyngitis is a sore throat. And probably a lot of us have experienced this. And a lot of times it goes right along with having sinusitis, rhinitis, and you might have like a runny nose. A lot of it's related to maybe a viral infection like the common cold. You get a nose drainage, sinusitis, and a sore throat all together. It could potentially happen. This also can be caused by bacteria, certain types of bacteria, viruses, trauma, dehydration, irritants such as alcohol or tobacco can cause pharyngitis. And we all know that one of the most common bacteria that causes some pharyngitis is strep. Most cases in adults, though, are virus. Strep is typically found in kids, usually. Signs and symptoms we are, familiar with. Unfortunately, throat soreness, dryness, pain, trouble with swallowing, and fever can be related to a pharyngitis. And then it is difficult to sort of determine whether it's viral or bacterial. It does need to be identified specifically so that it can be treated appropriately. Usually they kind of try to tell it apart by the fact that bacterial have enlarged red tonsils and exudate, nasal drainage, and local lymph node enlargement. The temperature is typically higher with bacterial pharyngitis. And if you take a peek at chart 33.2 on page 643, there is a table that sort of differentiates out the viral and the bacterial pharyngitis. So it gives you signs and some, like, how to determine the difference
between the two. It is important to, and that's why most doctors will go ahead and just test a strep on somebody just to be sure, because there's lots of complications if it is a strep infection that can occur. Those are listed on page 643 as well, on table 33.1, complications of a group A strep infection. Talks about rheumatic fever, acute glomerular nephritis. I think I talked about this a little bit in class. So that's why lots of doctors now are pretty adamant about ruling out strep before they treat somebody with pharyngitis. Again, if it's determined that it is a bacterial infection and they are given antibiotics, they need to be educated about the antibiotics that are utilized to treat the infection. They need to know that they need to take it all in order to treat the infection properly. It's just a picture of a rare occurrence that can happen with acute pharyngitis. It's epiglottitis. If they get inflamed, the epiglottis is that little flap that covers the trachea when a patient swallows food, and it actually can get swollen if there's an infection back there, and it can actually occlude their airway. So if that's determined, the patient's going to be watched very, very closely for losing their airway if they have epiglottitis. It typically occurs more in children than adults, but it is a rare kind of emergent situation that could occur with pharyngitis. Okay, moving right along to influenza or the flu. Most of us are somewhat familiar with the flu, unfortunately. Seasonal influenza is a flu. It's a highly contagious acute viral respiratory infection that can occur in all ages. Some forms of the flu can be very debilitating, especially to someone who is already immunocompromised. Severe headache, muscle ache, fever, chills, fatigue, weakness. It is a virus. And so we are doing vaccinations in order to prevent it, because we can't treat it with antibiotics as it is a virus. So we do have some antiviral agents out now that we can use once the symptoms are recognized, and go ahead and give it to try to fight off the virus. But we know that a patient who, elderly, young, people who are immunocompromised, this can be a very devastating virus to that patient that doesn't have the ability to fight off the virus and the symptoms. So vaccinations are made available throughout the country now for the flu, because it's been recognized that it can be so devastating. So we're trying to prevent it. Every patient has to get a flu vaccine every year, and that's because we try to take the strain of the virus. They try to predict it in order to treat it properly. So it's a yearly vaccine that has to be taken. Most patients can get it unless it's contraindicated. Teaching a patient to prevent influenza is one of the strongest ways that we can help prevent spread of the flu. They need to wash their hands, cover their nose, things like that. Stay home whenever they are sick so that they don't spread it. That's a great way to prevent it. And like I said, there's antiviral agents that we use. Once the symptoms are recognized as the flu, we can test them. To see if they have influenza. A lot of times they like to go ahead and treat them once they suspect that they have the flu, because it's actually more, the sooner we start it, once the symptoms are recognized, it's more effective. So it's good to go ahead and get it started once it's recognized, and it's more effective if they take it within the first 24 hours to 48 hours of onset of manifestations of the flu. Patient, as far as managing the flu, they need to stay in bed, they need to stay at home, increase their fluid intake unless it's contraindicated, and just really take care of themselves, and that's the best way to get over the flu. Pandemic influenza, we've all heard of H1N1 that was going around a couple years ago. These are flu viruses that originated in animals and have mutated to become infecting humans, and when that happens, It's difficult for the human to fight it off because we have not built up antibodies for this virus because it was originally in an animal, so it can be pretty devastating to a human. Then again, the antiviral meds, the Tamiflu, and the Relenza are new drugs out there that are pretty effective. However, like I said, they need to be started pretty early, and they're better. They work better when they're started early. These are expensive drugs too. That's one of the big issues with it. They're pretty expensive. They're about $200 a pop. So we've got to get it started. It's worth it though, if we can get it started early and it's effective. If you think about like an adult with a flu and they're missing work because they have the flu, if we can get Tamiflu started early, it can lead to less time off work and less interruption in their daily life. Again, moving on down the respiratory tract, we're going to go on to pneumonia. Pneumonia is an infection in the lungs. It's an inflammatory process that results in fluid in the lung fields. Typically, the inflammation is brought on by some kind of an infection agent that has been inhaled into the lungs. It can be bacteria, viral, an actual some kind of a inhalation of a toxic property that can cause inflammation in the lungs. So typical causes for pneumonia. So it's an inhalation of some kind of a foreign organism, and it can be a bacteria, virus, fungi, protozoa, even helminths, which is worms. It can be the inhalation of some kind of a toxic gas or fume and smoke. If someone aspirates, if they're getting fluid down into their lung that shouldn't be there, food or fluid, sometimes they can aspirate on their own vomit, and basically the introduction of that foreign substance into the lungs can cause an inflammatory response that leads to pneumonia, and it leads to fluid in the lungs, which makes it difficult for the patient to breathe. We all know that these can be community acquired, nosocomial, which means it's acquired in the hospital. Maybe they're introduced to some kind of a germ in the hospital, or invasive devices can introduce a bacteria down into the lungs. So that can cause a hospital-acquired pneumonia. Pretty high prevalence in the United States of pneumonia each year. A lot of it is hospital-acquired, and so we do what we can to prevent it. And we know that patients that are in the hospital already, typically they're ill, they're immunocompromised, so they're going to be more at risk for getting pneumonia. There's a table on page 648, or it's a chart 33.4. It talks about preparing a patient for preventing them from getting pneumonia, and it talks about the patients that are at risk. You know, it's the older patients who already maybe are immunocompromised, or it's the very young typically. And then remember, if you think about our surgical patients are at risk for pneumonia because they are not coughing and walking around, and those patients who have been immobilized by some other kind of medical condition are also at risk for pneumonia. So think about all those things that we do to prevent that in a patient. That's your IS, your coughing and deep breathing, and getting them up and moving around as soon as possible. So think about this, the clinical manifestations of a patient with pneumonia, what they're going to look like. They typically, with the inflammation and fluid in their lungs, they're not going to be making a good gas exchange, so they're going to have some hypoxia or hypoxemia, which is low oxygen levels in the blood. They're going to have a cough, generally, tachypnic, sputum production. They're trying to cough that stuff out of there. Muscle weakness, difficult taking deep breaths, and think about as you auscultate their lungs, they will probably have adventitious lung sounds. They'll have crackles when there's fluid. Wheezing could be heard if there's a lot of inflammation in there. That's what typically happens with inflammation in the lungs, is wheezing, because it's a constricted airway. Chest expansion may be diminished. They're not taking deep breaths. They could have a fever. They might be a little bit more tachycardic and appear dehydrated. They're just could appear very ill. So just think about all those manifestations of a patient with pneumonia. These are the lab assessments that we're going to do to assess a patient with pneumonia. We're going to get that sputum culture, and just make sure you review the proper procedure for obtaining a sputum culture. We want them to cough something, not spit into a cup. We want actual something that they've coughed up out of their lungs. They're going to put it in a sterile container, teach them how to get it in the container without touching the inside. CBC, of course, to see if their white count is elevated. ABGs, it's going to assess their oxygenation status. Serum bun and electrolytes, a lot of times that will help us, if you recall, determine their hydration level and make sure that they're adequately hydrated, and that will help them feel better. Diagnostic tests for diagnosing pneumonia. Once somebody comes in with these signs and symptoms, we'll go ahead and get a chest x-ray. It is the most common diagnostic test for pneumonia. It will help us determine whether there's inflammation and fluid in the lungs. It's one of the best non-invasive ways to diagnose pneumonia. You're all familiar with pulse oximetry, and that is monitoring oxygenation levels, and that can help us determine whether the patient is making good gas exchange or not. Bronchoscopy is a test that it's like a scope that they can take and go down into the lungs and visualize the actual bronchioles, and it can also do specimen samples. It can do biopsies through a bronchoscopy, things like that. Be sure to know patient care during a bronchoscopy. You want to make sure, typically they do some NPO status prior to the test, so that they don't aspirate on anything, and then it's gonna be one of those things where they have to numb their throat and make sure that they are not gonna gag when they insert the scope, and then the patient's monitored very closely. They're put on some twilight sedation, and then monitor closely until they wake up, and make sure that they're waking up and that they have a gag reflex when they wake up and return to the floor. And before they give them something to eat, they're going to make sure that they are able to swallow appropriately. Tuberculosis is a highly communicable disease caused by a germ, Mycobacterium tuberculosis. It can occur in the lungs. It is an airborne infection, so this means that when someone coughs, sneezes, sings, talks, the droplets are airborne, and then they are inhaled by others. So this requires an airborne isolation, which requires a very specific room, specific gear by the healthcare workers to protect them against it. So important things to know about tuberculosis is people can be exposed to it, and the germ can be put, down into the lungs, but it doesn't necessarily mean that a patient has active TB. They can have some lesions in their lungs that occur from an exposure, but a lot of patients are able to fight this off. And it's typically your patients who are immunocompromised initially that end up with tuberculosis. And that is like your HIV patients would be more prone to having it, more at risk, because they already have that immunocompromise. And actually TB has kind of been on the rise. You've heard it a little bit more lately because of the HIV. So basically, like I said, someone can be exposed to it, and the germ, this mycobacterium, goes down into the lungs and sort of causes an inflammatory response, which it's very rapid acting, and it can leave behind kind of like these granular masses, these lesions, and sometimes they're so small they can't even see them on x-ray. But like I said, in a very, very healthy person, these things could just occur there and never cause an active TB. If it does become active in a patient, if they continue to grow and are able to invade the patient, it can also invade other organs as well. The brain, liver, kidney, or bone marrow can be infected by the spread, but typically the initial infection is typically seen in the middle or lower lobes of the lungs. It can spread to lymph nodes. Okay, so early detection of TB is important, as with any other disease, basically.
It can have a slow onset, and so it's very important for the clinician to really kind of be aware and make sure that they determine whether somebody has these signs and symptoms. Their classic signs and symptoms, typically the big ones that people often associate with TB, is that night sweats and weight loss and this cough, this hemoptysis, so they have blood in their sputum that they're coughing up. So once somebody tells you that they've had night sweats, low-grade fever, they're coughing, it's blood-tinged, they have a loss of appetite, they're losing weight, and this has happened over maybe a month or so. And then you would begin to maybe dig a little deeper and ask questions about, have you traveled recently? Because sometimes if they've traveled to countries that don't do the vaccinations and infection control like we do in our country, the tuberculosis incidence is higher. So if traveling would put them at risk. If they've been exposed to anybody that's had TB, would also put them at risk. So those are your next questions when somebody comes to you with signs and symptoms as weight loss, low-grade fever, night sweats, and hemoptysis. And you're going to ask questions like, how long has this been going on? If they tell you it's been going on for the past month, I've had night sweats, that have been getting progressively worse over the last month. And then I'm starting to cough that has some blood in it. You're going to start thinking, okay, we need to do some further examination of this patient. So again here, once a patient comes in with these signs and symptoms, you're going to look further into their history and then do an assessment as far as listening to their lungs, monitoring their oxygen saturation, and just assessing their vital signs, and then having them list all of their signs and symptoms to see if they match your suspicion that they have TB. Once you suspect that they have TB, airborne isolation is warranted. You can go ahead and put them in airborne isolation, which is that special room that has that negative pressure that takes the air, it circulates the air and takes it outside. And then you're going to use in our institution that we do our clinical in at Christ Hospital, they do the PAPR, which is that helmet looking thing. I don't know if you've seen that on the floors yet. But basically what that does is it keeps the nurse from inhaling the air that's in the room, and you're only inhaling the air that's within the helmet that you're wearing. There's also special mask that can be worn to protect the nurse from inhaling the airborne droplets that are put out by a patient that has active TB. All right, so our goal here with tuberculosis is early detection, accurate diagnosis, effective disease treatment, and preventing spread to others. So we have ways of detecting for TB. First of all, I'll talk about the tuberculin PPD test is what we get every year as healthcare providers, and that's a screening tool for tuberculosis. And that is just to determine if a patient has been exposed to a TB infection. Screening in this way with the PPD test is recommended by the CDC for people with or at high risk for HIV infection, close contacts of people who have or are suspected of having infectious TB, people with medical risk factors such as chronic malabsorption, end-stage renal failure, diabetes, immunosuppression, and things like that. People born in countries with a high incidence of TB should be screened. Anybody in the medically underserved, low-income population that might have a higher incidence of TB. People with alcoholism and those who do IV drug use because their exposure is greater. And people who have who are in long-term healthcare facilities are screened frequently for TB. Okay, so the one thing that the PPD test tells us is that somebody has been exposed. It doesn't mean that they have active TB. So the next thing we need to do is a chest x-ray. So if somebody has a positive PPD test, we're going to next do a chest x-ray to determine if they have active TB or not. The other thing we can do is a sputum culture to look for the tuberculin germ
It's called acid-fast bacillus sputum smear that we're going to take a look at.
The acid-fast smear provides a rapid indicator of TB.
So that's sort of like a rapid test, and then if that's positive, we're going to send a sputum culture for the Mycobacterium tuberculosis. That is the definitive diagnosis. When that sputum culture comes back as a positive for Mycobacterium tuberculosis, that is a positive active tuberculosis patient. So again, this is just a slide that just verifies what I said, that just because somebody has a positive PPD does not mean active TB. It means exposure typically. And then we investigate further on the patient that has the positive PPD. It's essentially a screening tool that we use to define if somebody's been exposed, and then we do a chest x-ray and a sputum culture to do further evaluation of this patient. This is just a picture of a PPD test. It's only if it's greater than 10 millimeters in duration when it's called a positive test. There are people who are specifically trained to read these TB tests to determine if they're positive or not.
Okay, so we have some medications that we can give to treat tuberculosis. Our goal for the treatment is to make the disease non-communicable to others, reduce the symptoms of the disease, and effect a cure in the shortest possible time. We want to get these people better.
So just like some of our other disorders that we've talked about, like HIV, we put them on sort of a little cocktail of medication to treat them more effectively. If we put them on a couple of different drugs that work to treat the germ in a little bit different ways, we feel like they're more effective if we do more than one drug to treat them.
So the use of multiple drug regimens destroys organisms as quickly as possible and reduces the emergence of drug-resistant organisms. It's very similar to kind of how we talked about treating HIV.
So again, the treatment for TB is expensive.
It's more than one drug. It is taking medications that could
cause some side effects over a prolonged period of time. So the problem, again, with treatment for TB is compliance. They have to be able to afford it. They have to take them as directed over a long period of time. So this can be kind of difficult for the patient to follow, but they need to be very strict in adhering to this in order to get better.
Most of these drugs are listed on page 656.
The isoniazid, rifampin, pyrazamide, and ethambutol are all listed, and again, they're used in combination. And we'll review these in class, but I really encourage you to look at page 656. They are all set out on a table as far as side effects. There's multiple side effects of these meds, of course, so a patient needs to be educated about these so that we can make sure that they know what to expect and that they'll be compliant